by Dr. Rosano.
At the count of 3, 2, 1, we are on.
Good evening, friends, and a very warm welcome to the second session of this physician's training program in heart failure being conducted by the Heart Failure Association of India. I hope you all enjoyed the first session. We also have a collaboration with the Heart Failure Association of the European Society of Cardiology. And that is a good thing because we learn to collaborate with them and also get a chance to listen to some of the experts in this particular field. So, as is our norm, the first 10 minutes are going to be devoted to a recap of what we learned in the previous session. So, may I request Dr. Bhagirath Raghuraman to give us a recap of the previous session?
Thank you, Chopra sir. Good evening, everybody. So here's a quick recap.
Fine.
So we had a brilliant opening session on the very first day, and the theme was epidemiology and pathophysiology of heart failure. So the first talk was anchored by Dr. Harikrishnan. This was heart failure in the Indian context, pathophysiology of heart failure. So the summary of his talk is as follows. We have 26 million heart failure patients worldwide. So this is to define the magnitude of the problem. High mortality rate, 30% at 1 year. Huge economic burden. We know that most countries spend a lot of their overall income on battling heart failure. Prevalence of heart failure in India, we are now having more detailed statistics, but extrapolated data pegs this at 14.4 million. Heart failure burden increases with age. In India, the heart failure has a double burden, that is, rise in prevalence of risk factors and persistence of old age diseases. So, Dr. Hari spoke eloquently about various risk factors, which I've shown here. Also making the grade are the rheumatic heart disease, congenital heart disease, endomyocardial fibrosis. Focus on infectious diseases, leptospirosis, 4% had heart failure, and dengue fever had 13% heart failure. And now we have data from the COVID recovered patients who also have heart failure. Indian data of heart failure, we now have robust data that is accumulating. The various registries are the Trivandrum Heart Failure Registry, the Inter-CHF Registry, Kerala Heart Failure Registry, which is probably a pioneer in this arena, the Indian College of Cardiology National Heart Failure Registry, and the National HF Registry, which is ICMR funded. So all of these have got significant data now. So we'll soon have a robust database and have our own statistics to speak of. So 10 take-home points, the take 10 from the talk of Dr. Hari, that is emerging data from various registries are soon accumulating and we'll have national statistics. The Indian profile of heart failure patients is younger patients, predominantly male patients, that is 70% are male and 30 female. Distribution, heart failure with reduced ejection fraction constitutes about 65% of the patient profile. Heart failure with mid-range ejection fraction is 20%, and heart failure with preserved ejection fraction is 15%. Etiologically, the heart failure components are ischemic cardiomyopathy, almost 65 to 70%. This forms the bulk of the heart failure patients in India. Dilated cardiomyopathy is 15%, and rheumatic heart disease, which was earlier one of the main contributors, is now 6 to 8%. Mortality rates, we all know that the short-term and the long-term mortality is high. We have some statistics now. The in-hospital mortality is 8%, 1 year mortality is 30%, 3 year mortality 45%, just less than half of them survive, make it to 3 years, and 5 year mortality is 60%. That means that at the end of 5 years, more than half of the patients would have perished. Some more take-home points. Guideline-directed therapy improves mortality. We all know that, and we have enough evidence from various meta-analysis data. only 25 to 40% receive guideline-directed medical therapy. So this is the sad part, and I think it's the onus is on us as well as the entire medical fraternity to make sure that most of our patients receive the guideline-directed medical therapy. Readmission rates is as high as 30% at 1 year, and the higher the readmission rate, the greater is the mortality. Heart failure with preserved ejection fraction probably has better outcomes than heart failure with reduced ejection fraction, particularly in Indian patients, and quality improvement programs may benefit our patients. Dr. Hari also spoke about issues in management of heart failure. There are accessibility issues, availability issues, and affordability issues, the 3 A's. So the accessibility issues, emergency medical facilities, well, it is more clustered in the cities and metros. As we go to tier 2 and tier 3 cities, the accessibility to emergency medical facilities becomes less and less. Also ambulance, we have a good network in the cities, but in the peripherals, this is again leaves much to be desired and improved. Availability issues, heart failure therapy enabled centers, those state-of-the-art centers having various mechanical circulatory support devices and so on are again clustered in the cities. That's where the bulk of the patients are, whereas those in the tier 2 and 3 towns and cities do not have access to these advanced centers. Affordability, device therapy is expensive. We have data from Dr. Amit Vora's article published in the Indian Heart Journal 2017 that only 17% of patients who needed devices actually got it. And that's because there was affordability issues. Many patients have to fund it on their own. There's no insurance or no funding available. So even though they actually deserve devices, they didn't get it. So how to solve these issues? Dr. Hari spoke about how we can address these issues, accessibility issues, establish centers of excellence. Well, again, the government is going in a very big way to have centers of excellence. We also have labs coming up which can afford quality care, and also a good, robust referral system. Affordability can be improved by control of drug prices, that is capping the cost of drugs. Generic drugs are now more widely available. There are various government schemes, particularly the Ayushman Bharat scheme, which is aimed to address these issues, and of course, subsidies from the government. We can also make use of technology, which is now widely available. The handiest technology that is now accessible to one and all is the mobile phone. We also can make use of telemedicine facility, wherein we can access the remotest of villages and provide quality care as well as advice, and also enlighten them when to refer for more advanced care to the tier 2 and tier 1 various cities. We also have the ASHA workers who have now been given tablet-based interactive system, wherein they can immediately interact with the medical fraternity to give quality care. Prevention is better than cure. We know that the faster you establish primary PCI, door to balloon time, door to needle time, you have better results, and the chance of such patients getting into the population of heart failure is very much reduced if you are able to establish a good system. Rheumatic heart disease, the age-old penicillin prophylaxis, and for congenital heart disease, screening of newborns can go a long way in preventing the onset of heart failure. Next, Dr. Hari also spoke about the pathophysiology of heart failure, and he alluded to about the consensus universal definition 2021 of heart failure, which I've shown here in this slide. He also spoke about the new heart failure classification, the various terminologies. So the heart failure with reduced ejection fraction is less than or equal to 40%. Heart failure with mid-range ejection fraction is 40 to 49%. Heart failure with preserved ejection fraction more than or equal to 50%. And a new category, heart failure with improved ejection fraction. It is called HF-ECG, more than 10% increase from baseline ejection fraction. Last slide, heart failure, pathophysiology and treatment. So this is a snapshot of the beautiful article from Maron and Rocco, published in 2011. So this shows both the pathophysiology as well as various drugs where they act in the sequence of heart failure. Next up, we had a very beautiful and very illustrative talk by Dr. Rosano. This was regarding the personalized approach to the management of heart failure patients. So he spoke about how we conventionally up-titrate medications of heart failure, that is the ACE inhibitors, beta blockers, mineralocorticoid antagonists, ARNI, ivabradine, in that order. And therapies are either for acute heart failure or chronic heart failure. So you have a gap in between. That is, the patient with acute heart failure has been treated, the patient is discharged, goes home, and then the chronic heart failure medications then come in. But there is a gap between these two sequences, between the acute and the chronic. So that is what we call as the post-hospitalization period. And in this period, the all-cause mortality and morbidity is the highest. That is at 1 to 3 months after discharge. So this zone is something that needs our attention. Adding therapies is adding life. Many times, the hitherto concept of keeping the medicines down to minimum has now given way to adding on therapy to make sure that the overall outcome of heart failure is much better. We also know that all medications in full force and full implementation has best results both in terms of morbidity and mortality. Difficulties in implementation of medications, both clinical and logistic difficulties, have to be overcome by one and all so that you are able to establish guideline-directed medical therapy to all patients. The other difficulties, only 25% of patients took medications in the required dose. Now, this is disheartening, and we all know that we have to step up at multiple levels to achieve a higher percentage. Many of them had side effects, bradycardia and hypotension. So again, this probably hampered dispensing of medications. Meta-analysis data shows that heart rate reduction is more important than the dose of beta blocker achieved for both morbidity and mortality statistics. We have data to say that beta blockers with ivabradine is better than beta blocker alone towards lowering heart rate, improving EF, and reducing BNP levels. A small note, Dr. Rosano said about the SGLT2 inhibitors. They have minimal or no effect on heart rate as well as blood pressure. So they have this advantage that they can be added on and the dose can be escalated, because many times in other medications, heart rate and blood pressure are limiting factors. The DAPA-HF trial showed the significant reduction in morbidity and mortality to the tune of 17%. All patients with or without diabetes had benefit. So the HbA1c levels didn't really matter regarding the initiation of therapy. The sotagliflozin had very early and significant benefit as compared to the placebo in the soloist study in terms of reducing cardiovascular death, hospitalization from heart failure, and urgent treatment for heart failure. So Dr. Rosano spoke about what is the new approach or standard of care. We have to move away from this stepwise introducing of medications and start all therapies all at once. ACE inhibitors or ARBs, beta blockers, MRA, SGLT2 inhibitors are frontline. Ivabradine and hydrolysine isosorbide dinitrate are the next on in this sequence. So what we need to do is start all together to achieve better results. We have better data in terms of LV remodeling, lower hospitalization, lower rehospitalization data, and lower mortality. This saves time, because if you have to follow the sequence of treatment of heart failure by gradually and graded increasing in the dosage of medications, it's likely to take 28 to 56 weeks. This is valuable time lost in the lifeline or lifetime of a patient with heart failure, and many times the patient may die before this 56 weeks is achieved. So it's good to start all medications at the same time. Again, emphasis on the mainstay of treatment, ACs, beta blockers, MRA, and SGLT2 inhibitors. So the new algorithm, dapagliflozin, beta blocker, ACE inhibitors, or ARB, ARNI, MRA, diuretics, depending on the patient phenotype, blood pressure, or presence of atrial fibrillation and chronic kidney disease. These become the modifying factors for the treatment. Future stratification of heart failure patients is going to be followed by the bioprofiling of patients. Now, this is a new concept. We look into the genomics, epigenomics, metabolomics, and lipidomics. So these are new concepts wherein you're able to completely profile each patient and customize medications, both in terms of what medication works for them as well as the appropriate dose for them. And this will tailor heart failure therapy better for each patient. Further, imaging, biomarkers, and artificial intelligence are likely to stratify these patients better so that therapy is more effective. Last talk was by Professor C.N.Manjunath, my teacher and my professor. Sir spoke about evaluation of heart failure, that is the ECG, chest X-ray, and the 6-minute walk test. It was a delight for us to see so many examples. It was a typical professorial talk, teaching talk. ECG helps in the etiological diagnosis, myocardial performance, rhythm disturbance, conduction abnormalities, both for prognostication and decision making. Helps to identify candidates for CRT therapy, that is the mandatory criteria of a left bundle branch block and the left bundle branch block pattern and QRS with more than 150 millisecond and EF less than 35. Heart failure with preserved ejection fraction can be missed on an ECG because oftentimes this is normal. Heart failure with reduced ejection fraction, invariably the ECG is abnormal. Persistent ST elevation can be a giveaway in terms of an LV apical aneurysm. And of course, patients with pericarditis can have low voltage complex as well as electrical alternance depending on the degree of pericardial effusion. Certain other findings, S1Q3T3 in pulmonary embolism, valvular heart disease, right axis deviation, left atrial enlargement, right ventricular hypertrophy. This can be used to grade the severity of mitral stenosis. PVC burden more than 10% can cause PVC-mediated cardiomyopathy. Epsilon wave can be a giveaway in terms of arrhythmogenic RV dysplasia. Cardiac amyloidosis can present with low voltage QRS complex. Heart failure with preserved ejection fraction can have left ventricular hypertrophy and atrial fibrillation. Digoxin toxicity can present with bidirectional VT and paroxysmal atrial tachycardia with block. There is also an example of flecainide-induced proarrhythmia and artificial intelligence in ECG. This is the digital stethoscope study that is currently being studied in Sri Jayadeva Institute of Cardiology, and we are eagerly awaiting the data from this study. The next part of the talk was on chest X-ray. Professor Manjunath spoke about the pulmonary edema features, what the criteria for cardiomegaly are, and the grades of pulmonary venous hypertension, how on the chest X-ray itself you can extrapolate what is the pulmonary capillary wedge pressure by just seeing the chest X-ray. If you see cephalization, it's 12 to 18. Interstitial edema is 19 to 25, and alveolar edema more than 25. And also sequentially, when the patient improves with treatment, you can see how the pulmonary capillary wedge pressure will reduce, and that will correspond to the picture on the chest X-ray. Calcified LV aneurysm, again, the treatment of choice, since it's a non-viable myocardium, it is a DORS procedure, and features of constrictive pericarditis on chest X-ray were discussed. Last part of Professor Manjunath's talk, the 6-minute walk test, more important in the in the COVID era and the post-COVID era. Safety issues, always be alert. Many times this is taken casually, but we can have patients who just collapse, and there may not be enough personnel available for resuscitation. A crash cart with a defibrillator should always be handy with emergency medications. And of course, this 6-minute walk test helps to assess the functional capacity of the patient. It is safe, cost-effective, and reproducible, and an invaluable test in identifying patients with heart failure, as well as to see how they fare. Pulmonary hypertension can also be assessed, and the response to treatment can also be assessed by this test. Thank you, everybody.
Thank you, Bhagirath. That was an excellent summary of the previous session. And I would urge the attendees to go to the website. Whether you attended the first session or not, it is worthwhile to go through these slides because it summarizes everything that was talked about in the first session. And now for the main part, may I invite Dr. Santosh Satish and Dr. Beshwa Mohan to please carry on with the proceedings. Santosh, over to you. You are muted, Dr. Santosh.
It is muted.
And Dr. Beshwa Mohan, both of you are muted. Please unmute yourself.
Santosh, you are muted. Can you just unmute yourself? Bishop Mohan, unmute.
Unmute, please.
Can Anand do it?
No, sir. They have to do it on. They have to do it.
Yeah, I managed to do it.
Yes, fine.
There was some problem in the. It is not getting unmuted as trying to.
Okay,
Dr.
go
Bishop,
ahead.
you
Go
can
ahead.
also unmute yourself, sir.
Okay, let's start. Dr. Satish, it's all
Yeah.
yours.
So today we have, after the recap, we have Dr. Mohanan, who is going to talk to us about evaluation of heart failure echocardiography. Thank you, Dr. Mohanan, for joining us, and you can start your presentation, sir.
Sure. I hope it is visible.
Yes.
Yeah, it is.
Thank you. Thank you. Thanks for the opportunity, Dr. Chopra, Dr. Harikrishnan, and my erudite chairperson, Bishop, and Santosh. I cannot claim to be an expert in echo. Maybe I was doing it for the last maybe 32 years. That makes me a semi-expert, but I am sure my younger folks will know it much better when it comes to the newer modes of echo. Evaluation of cardiac function is a fundamental issue for every cardiac imaging technique, and possibly echocardiography is the single most useful diagnostics test in evaluation of heart failure. Now, echo imaging has several targets: assessment of myocardial structure, function, the now associated valvular dysfunction, looking at assessing the hemodynamics, and so on. So this is just a comparison of the various imaging techniques available. But as I said, the most easy to do is echocardiogram, and we have Professor Venugopal who is going to educate us about the other modes of imaging. Echocardiogram helps us in very many ways. It helps us in the diagnosis, in the prognosis, and of course helps quite a lot in deciding the therapy, especially when it comes to the usage of certain devices. The transthoracic echo remains the method of choice. No? It's very seldom that, unless you have any compelling situations like a very poor echo window, which is one of the bane when you do a transthoracic echo, generally the method of choice is for assessment of structure and function is a TTE. And of course, the conventional 2D echo helps us, and I don't need to tell you about the various views that one opt for, but you also look for any secondary mitral regurgitation, especially if there is an additional LV enlargement. And of course, it helps us in the etiological diagnosis, whether it is a dilated cardiomyopathy or the wall motion abnormality, or if there is a hypertrophic cardiomyopathy, or sometimes rare infiltrative diseases like an amyloid. This could be possibly the best way to go. When you do an echocardiogram, essentially you are going to subtype into the two phenotypes, the common, of course. I'm not forgetting the mid-range ejection fraction business, but essentially it is either HF or HF, and then you assess if it is a reduced ejection fraction, you look at the global and segmental LV dysfunction, and then look for any reversible causes like underlying coronary artery disease. If the ejection fraction is normal, more than 50%, then look for any valvular diseases. Definitely look for the structural LVH or inlay enlargement, and then you can say that this is a HF. Of course, this is another which will help us in identifying the etiology of the various causes of the either HF, and you have a long list when it comes to a patient who is presenting to us with heart failure with preserved ejection fractions. If you look at the echocardiographic modalities for evaluation and risk stratification, as I said earlier, the initial assessment is just to identify the two phenotypes by assessing the left ventricular volume and ejection fraction. You also, especially, you concentrate on the LV mass and the LA size if it is a HF-PEF. And if you have an additional advantage of a 3D echo, then your assessment of the left ventricular volume and the function become much more simplified. I will come into the disadvantage of the conventional echo method and some advantages of the 3D echo in the later slides. And of course, now it gives us an idea about the evaluation of the heart failure patient, assessing the left ventricular diastolic function. You're looking at the filling pressures, assessing the boundary artery pressures, looking at the left ventricular wall thickness, looking for, again, as I said, for secondary mitral regurg, assessing left atrial volume, looking for any presence of dysynchrony, which will help us in devising and then deciding on the necessity for any devices. Look for the newer modes of echo has given helping us looking at the deformation of the myocardium, and even now the lab, it is not available clinically, but the intracardiac flow mapping, which has been there for quite some time, not came into the lab yet, still in the laboratory, not in the benches, but we are going to see a lot of newer methods of echo assessment, ultrasonic use also in patient with heart failure. As I said, basically you look at the ejection fraction so that now you can classify into the two type phenotypes. You can assess the risk, and of course, at times plan your devices. You also look at the non-EF indices, as we said about the presence of or absence of mitral regurg, then the transmitral and the annular velocities. And these are the ways by which which will help you in identifying these or assessing these measurements. Look at left atrial volume, and of course, you have to look at the right ventricular pressure, and the right ventricular function has to be assessed. And finally, look at the regional function, and that will help us in deciding on therapy. So initially, we are going to concentrate more on the left ventricular function. Of course, if you have gone through the diagnosis, even though classically we say that diagnosis of heart failure is essentially clinical, echocardiogram and biomarker, these three are the most important three diagnostic triad that we look at in every patient with heart failure. Looking at the looking for the systolic dysfunction, we know about the definitions of it. The most common causes of systolic dysfunction will be coronary artery disease, as we have seen in the all of the Indian data, not to speak of the other international data. And of course, then the cardiomyopathy. Still, we have rheumatic and other valvular disease. So if you look at the assessment, the conventional assessment of left ventricular ejection fraction, see, measuring the LV ejection fraction has been in possibly the T-Coles method or even the eyeballing, which most of us do for ease of it. See, when you do an eyeballing of the LVEF, there could be a variability in the inter-observer variability, something like 8 to 10%. And even the T-Coles method is not above board. So possibly the best method is a biplane Simpson's method, and that possibly give us the best value assessment of it. I do agree that now we most of the time, see, when you start an echo, this is the usual thing that we do. You a 2D assisted mode measurement, which makes it much more simpler method. But then, as I said, there are lots of errors, especially when you have difficulty in identifying the endocardium. So though it is a very widely practiced method, this is possibly not the method of choice. And as we discussed, possibly the best method will be a assessment by Simpson's biplane. Basically because the difficulty at times, the detecting the endocardial borders are, and more importantly, the ejection fraction is dependent on the loading condition. So it's better that we do assess the ventricular volume in a more detailed way, and this will possibly avoid the inter-observer variability to an extent. I'm not saying this is the, now as you could see, then there could be a 2 or 3% difference, but conventionally calculations of the left ventricular volume and ejection fractions are ideally derived from the biplane Simpson's method. At times when you have difficulties in tracing the endocardial borders, a contrast agent is recommended. And it is said that when less than 80% of the endocardial border is not adequately visualized, it is better that you do a contrast agent. Now we have the availability of so many contrast agents, this may become much more easier. I was mentioning about some of the advantages of 3D echo for left ventricular volume and the EF measurement. That definitely the comparative data has shown that assessment of left ventricular volume, especially EF, is possibly best with the 3D echo, which has almost the similar validity of CMR, which we are going to listen from Professor Venugopal. One of the more important, maybe a little more tricky or more difficult area is the assessment of diastolic function and identifying diastolic dysfunction, which basically will give us an idea about the elevated end diastolic pressure without an increase in the the LV end diastolic volume. And the typical scenario where you will see are these, and it's a very many phenotypes can produce diastolic dysfunction, diastolic heart failure. Basically, now the criteria, it is not the EF criteria alone, which we will discuss, and what are the other criteria. Of course, whenever you say it is HF, we mean that the LVEF is more than 50%. And of course, you have to have other indices of diastolic dysfunction. You also look at, as we said and showed in the previous slide, you look at the assess the left ventricular mass index, and also look for left atrial volume, which again is becoming absolutely important these days in assessing, giving us a total picture of LV diastolic dysfunction. The determinants of the diastolic functions are myocardial relaxation. This is what you're going to assess also. The chamber stiffness, the compliance, the atrial function, pericardial restraint, ventricular interaction, and of course, finally, coronary blood volume. And basically, these are the things that you assess when you check for the diastolic function. It will be helped by the conventional 2D method, the tissue Doppler assessment. And there are very many things that, this gives us an idea about a grading of the diastolic dysfunction. The pulse wave Doppler, the mitral, and the color mode mapping will give us an idea about this is the grade 1, where you have a DT of more than 240 and your EA velocity is reversed less than 1, which is the normal one. And you have the grade 2, and finally where you have the restricted sort of filling, where you could see that the EA becomes sometimes more than 1.5 or 2. In this, it is not the pulse wave Doppler which help us. We also have a host of other methods like the color mode and the tissue Doppler, which will help us The E prime ratio is another very useful index which will help us in identifying diastolic dysfunction. And finally, the left atrial pressure and the volume calculated will help us in identifying patient with HF in a substantial number of ways. So as we were discussing, you have a normal pattern, then the impaired milder forms of diastolic dysfunction. Then we have the pseudo-normalized pattern, where you have a moderate diastolic dysfunction. And here is a situation where the left atrial pressure is increasing. And finally, you have, as I said, when the EA ratio becomes more than 2, and this will be the corresponding tissue Doppler signs where you have the changes in the E and E prime. This is again a repetition of the slides what we have seen, the tissue Doppler imaging and the color mode, which helps us to sort of cement our observation that this particular patient has a diastolic dysfunction. So basically, you look at of course, you are looking at the IVRT and the relaxation of the left ventricle by assessing these. And also you're looking at the EA ratio, and of course, looking at the LA pressure, and you have a graded response of a graded way of assessing from mild to severe diastolic dysfunction. So you have to have a diastolic function assay analysis will include an integrative approach. See, you look at the structural changes, look for the LV mass, look at the LA size and volume, and then you assess the mitral flow, pulmonary venous flow, and the tissue Doppler imaging, and finally the pulmonary artery pressure. And this integrative approach gives us an idea about the severity of the diastolic dysfunction. And this, in short, will be the major parameters of the diastolic dysfunction. Santosh, I am not seeing my timer. I hope I am not within my time.
You have 3.5 minutes to go.
Okay. Ananda, your timer is missing. Okay, of course, we said about the 3 criteria. Even if those 3 criteria are not there, even if you have 2 positive criteria, you can say that there is presence of LV diastolic dysfunction. Another area where the echocardiogram help is to identify the causative factor which causes the heart failure, whether it's mitral valve disease or aortic valve disease, and assessing the stenotic valves, assessing the regurgitant valves, and of course looking at the various valve motion if the underlying cause is due to coronary artery disease. At times, it may not be very easy to identify between a dilated cardiomyopathy and an ischemic cardiomyopathy, but these are the situations where the special types of Doppler imaging using a 2D strain. We can have a longitudinal strain or a circumferential strain or a radial strain. I will just come into that in a short while. So the prognostic value, see, all of these variables that we have discussed till now will also help us in prognosticating in a given case, whether it is a HFrEF or a HFpEF. We have enough and more data which showed the survival depends upon your diastolic dysfunction, your pulmonary artery pressure. Every indices that we have discussed has shown a relation with the prognosis of the heart failure patient. And one of the even simple thing like IVC diameter and which can be easily measured is correlated with your NT-proBNP level. So we have enough and more data which showed that every indices that we have discussed till now has an important relevance to the mortality and the prognosis. Now, this is just to give you an idea the progression of the mechanical dysfunction from stage A to stage C. And in these, apart from whatever we have discussed, the wall stress, by the estimating the GLS and the circumferential strain will definitely help us. The TDI velocity, the various forms of it, even though it's a class 2 recommendation, it has helped us in strain, has definitely helped us in assessing maybe a better global longitudinal strain, may be a better index of your ejection fraction, especially when you are assessing subclinical LV dysfunction. So the same way, the usage of the very many strains, the longitudinal, circumferential, and the radial strain has helped. All the three has helped us in assessing the left ventricular function in a better way. This just give you an idea about the various types of. I'll just take 1 minute, Santosh and Bishop.
Please go ahead. Please go ahead.
Yeah, these. You can just, this is just give a comparative idea about the longitudinal and the circumferential strain in very many diseases that you will see. As I mentioned, the strain becomes, and the spectral tracking and the GLS and the circumferential strain becomes very important when you are assessing a patient for cancer therapy, and he comes back with a dip in the ejection fraction, and the GLS will help us much better than the conventional ejection fractions methods assessment. See, this is something which is possibly in the offing left ventricular TIF dynamics helping us. This is the conventional EF way, and this is the Simpson's way, and finally this is the 3D way. The 3D definitely has an advantage over this. We have discussed the advantages of 3D over the conventional method of assessing ejection fraction. This is something, as I said, the intracardiac flow is something which we have been discussing for the last 12 years. It has not to be marketed yet, but this looks very, very, very promising, and possibly that will again help us in assessment. This is my last slide, which you have already seen. So echocardiogram becomes an absolute easiest tool for assessment of heart failure, be it any phenotype, especially the HF and the very many types of HF. So our idea will be to assess the volumes and functions, look at the structures of LV mass, look at the LA volume, and if it is available, try to use a 3D assessment of ejection fraction. It's not necessary that everybody should have a 3D to assessment of EF, but also look at concentrate on the diastolic and the filling properties, look at the right ventricular function and the right ventricular pressure, and it will be a very useful tool in your common practice in your day-to-day life. Thank you for your kind attention.
Thank you, sir. Thank you so much for that excellent talk on the length and breadth of echocardiography for heart failure. And before we go to the questions from the audience, I would like to ask you, do you think among all these new techniques, do you think global longitudinal strain or 3D echocardiography, which one do you think will be the future?
We have only smaller data comparing GLS with 3D, but maybe for the easiest, for the pundits, maybe GLS is, now we have a paper which I showed in the BMC, which showed that GLS should be the ideal way, especially if you are assessing subclinical left ventricular. But when it comes to the regular, even rather than the Simpson method, if you have a 3D, possibly that is better.
Thank you.
Good evening, sir.
Yes, Bishop.
Sir, there is another, side of this. There are majority of the physicians in India, they have just basic echocardiography.
True.
So what is your suggestions for them, that what focus they should see and then they treat? Because there is too much of a volume of the patients, but there is a basic echocardiography, one person doing everything. So what is the take home message for them?
We are all jack of all trades, Bishop, unfortunately. Yeah, I do agree that even though we have now a crop of echo technicians coming up, but as you said, I think the important thing is assess your ejection fraction by the Simpson's method. Don't spend too much of time for the T codes and spend your time on that. Try to do that. Don't look at the 3D or GLS. Unless, as you said, in a special situation where possibly it may be benefit is when you are thinking in terms of a chemotherapy. Conventionally, do concentrate on EF by the Simpson's method. Diastolic function, that is an area where we possibly forgets. And we pay little lesser attention. Please give as much attention to the diastolic function assessment, and all the three parameters, simple three parameters can be done, and you can have an assessment, a very good assessment. That will be my take-home point.
Thank you, sir. Any other questions from the panelists?
Mohan sir, I think more emphasis on the volumes in 3D, particularly we can now do color coding of segmental volumes, and also for right ventricle assessment, particularly in patients who are slated to receive an LVAD. So here, when you do a 3D recon, you will be able to get a multi-dimensional view, and that would probably go one step ahead in assessing whether the patients are suitable for a single chamber support vis-a-vis BiVAD.
I mean, that is the expertise, and you are an LVAD guy, so naturally. So what about CRT? What is the, I mean, I know that you also put CRT. What will be your assessment? Which will be the best assessment for this energy, Bhagirath?
So MADIT2 criteria, that's all. Left bundle branch block, QRS width more than 150 milliseconds.
Echo assessment. I'm asking echo. I mean, you step, yeah.
So we put many indices together, but didn't really find any predictive accuracy in various parameters. So we still go by the conventional MADIT2, and we've had very good results with that.
Any further questions? Dr. Chopra, Dr. Harikrishnan, any?
No, I think let's go on to this next talk. Hello, Dr. Rosano. Nice seeing you.
Thank you, Dr. Mohan.
Thank you. Appreciate it.
Dr. Krishna, pleasure being here.
Thank you. Good evening.
Good evening. And
Put
the next talk by Dr. Venugopal.
No, it's by Professor Rosano.
Oh, is
Yes,
it?
sir. There's been a small
Rosano,
change.
we have
Professor Rosano has to go for another talk. So,
Oh, okay. Fine.
yeah,
So,
Professor Rosano, you could go ahead and share your screen, please.
Yeah. You can please start, sir.
Okay, it's here. So thank you once again for having me here with you. And what I will do in the next 20 minutes, I will be discussing the importance of cardiac metabolism in patients with heart failure. Now, we know that at rest, we have a cardiac metabolism that is switched mostly to the use of free fatty acids, with 60% of energy coming from utilization of free fatty acids and only 40% from glucose. This, despite the fact that the use of glucose is much more efficient because it leads to more production of ATP per mole of oxygen as compared to the use of free fatty acids. But there is a reason for that, is because glucose at rest gets stored into glycogen and therefore builds up the stores that then can be used when there is an increased metabolic need. So when there is an increased metabolic need, there's this switch from free fatty acids to glucose, with up to 70% of glucose utilized to produce energy. And this will lead to a better and a greater metabolic efficiency of the myocardium. So you understand why it is important to have a good glucose metabolism in a heart, and how the heart should be able to switch from free fatty acid to glucose very fast. Now, however, in patients with heart failure, we observe some metabolic changes, which are an impaired capacity for glucose uptake and glycolysis, a decrease in carbohydrate oxidation, and an increase in free fatty acid oxidation. These, together with a reduced contractility, leads to a further decrease in cardiac contractility because there is less energy available for the actin-myosin interaction. But also there is less energy for the reuptake of calcium from the sarcoplasmic reticulum, leading to diastolic alterations. Now you can clearly see the importance of mitochondria in heart failure and the mitochondrial changes that occur in heart failure. Here on the left, we have the normal myocardium where the mitochondria are very nicely and well aligned with the normal cristae. And on the right, we have this failing myocardium where the mitochondria are small and rounded, with the cristae that tends to break up. So that basically tells you that the failing myocardium is less metabolic efficient, and in part because of the altered metabolism, in part because of the alteration in the mitochondria. So these changes, as I said, lead to less production of ATP, with less ATP reserved, that on one side may have an effect on the reuptake of calcium sarcoplasmic during diastole, with a subclinical impairment of diastole that during increased demands, such as an increase in heart rate, increase in blood pressure, will lead to diastolic heart failure. On the other hand, it may also lead to a decrease in ATP available for the actin-myosin interaction, with a subclinical impairment of systole, with a worsening of systole, and therefore favoring the systolic heart failure. Now, we can see that in specific phenotypes, these changes are very much heightened. I mean, for example, in diabetes, in patients with insulin resistance, we can see that in the plasma, there's in patients with diabetes, there's more glucose, but the glucose is much less utilized by the myocardium, which tends more to extract and use free fatty acids. So we even see that in patients at increased risk for heart failure, there is an increased use of free fatty acids, less use of glucose, and that leads to less production of energy. So the phosphocreatine ATP ratio is an index of energy production. And you can see that in patients with diabetes, in this case, that is very much reduced. And these were patients with diastolic dysfunction. That basically tells you that if you have an impaired production of ATP, you are more prone to develop heart failure. Now, there is evidence that the carbohydrate and free fatty acid metabolism is altered in patients with heart failure. Previous studies have shown that in heart failure patients compared to normal, they have a decreased carbohydrate oxidation and an increase in free fatty acid oxidation. And the importance of glucose metabolism is clearly shown in this experimental work. I just want you to focus on the top left panel. These are isolated hearts that were fed either with free fatty acids in yellow or by glucose in white. You can see that after ligation of a coronary, there's a decrease in energy production, in energy. But then once the ligation is eased, then you can clearly see that those hearts that were given glucose had a better recovery of left ventricular function as compared to those who received free fatty acids that basically had an impaired or less recovery of the ventricular function. So that tells you how important it is to use glucose for the heart. Now, in the past, we had different approaches for the treatment of heart failure. Either one, to decrease the oxygen energy consumption by reducing preload and afterload, or to increase contractility. But all drugs that led to an increase in contractility, they also increased oxygen and energy consumption. And therefore, they used all the stores of energy. They led to an impairment of the reuptake of calcium and therefore facilitated arrhythmias. So there is another possibility of acting on the failing heart, so to increase the energy production without changes in heart rate or blood pressure. And this will increase the contractility without increasing the oxygen energy consumption. Now, we can, of course, optimize cardiac metabolism by reducing heart rate. And this is shown by the, it shows you exactly how the glucose uptake increases here in blue with 18 FDG that is uptaken by the heart with beta blockers. And the fact that this is purely related to heart failure is shown by the fact that there's an increase in cardiac metabolism and in glucose uptake using another way of reducing heart rate, that is using ivabrutin. So basically, we can restore some of the altered metabolism by reducing heart rate, but also we can work on cardiac metabolism. We can favor the uptake of glucose, and in this case, the metformin or the GLP-1 may have an effect on increasing the glucose. There's data from intracoronary studies with pyruvate that pyruvate increases contractility. We may also act on increasing the free fatty acids with the CPT1 inhibitor, like niacin, but you need very high dose of niacin in order to have that inhibition. You can block the products of the beta oxidation with etomoxir or dichloroacetate or paraxylene that are highly toxic, or you can block directly beta oxidation with drugs like trimetazidine or ranolazine. Now, I have to say that in order to block the beta oxidation with ranolazine, you need very high doses that are not usually used in clinical practice. So for the current doses of ranolazine, there's no significant effect on beta oxidation. So the only feasible effect at the present is the use of trimetazidine. Also, there's a different possibility of increasing the Krebs cycle efficiency by using amino acids or to use other substances that may favor the transfer of electrons on the myocardium. Now, going to clinical and understand clinically what all these hypotheses mean. Now, if we look at data with metformin, we see that metformin in clinical practice leads to an improvement in survival and event-free survival. And this has been repeated several times, so it is clear that improving glucose sensitivity of the heart has an important effect. But the drug that has been mostly studied in patients with heart failure is trimetazidine. Now, you may remember earlier the study I showed you with patients with heart failure having less energy production of their myocardium. With trimetazidine, you can clearly see there's the cardiac metabolism is normalized, bringing back the energy production to the level of normal subjects. We and others have shown in the past that the use of trimetazidine in patients with heart failure is effective in reducing left ventricular and diastolic and systolic volumes and in increasing left ventricular function. And this is true in diabetic cardiomyopathy, in the idiopathic dilated cardiomyopathy, and others like the Milan group have shown that trimetazidine decreases BNP production. Now, we don't have a big randomized clinical trials on ranolazine. This is the study we have so far, which is a study in 860 patients, put together by Gabriele Fragasso, myself, and an international cohort of colleagues, and where we showed that trimetazidine was associated with better survival and better cardiovascular survival compared to those patients who were not taking trimetazidine, so a clear effect. But whenever I discuss about results, I always like to show meta-analysis, because it's only with the meta-analysis where you can see the consistency of data. And in this and in other meta-analysis, there's a clear effect of trimetazidine on left ventricular function in both patients with ischemic cardiomyopathy, non-ischemic cardiomyopathy, an improvement in New York Heart Association classes, and increase in exercise duration. So it's a clear effect of tremetazidine. Now, and also this is associated with a reduction in all-cause mortality and in cumulative events. Now, another way of approaching cardiac metabolism is using another small molecule. Now, we know that the mitochondria, and I showed you the image of the mitochondria earlier, that are small and rounded. And this is because a protein on the surface, it's called cardiolipin, is altered and therefore alters the crystin. Now, there is a small molecule like Bendavia has an effect in restoring the function of the cardiolipin and increases and favors the electron transport over the mitochondria. And Bendavia in animals with heart failure is shown to increase the ATP production because of this effect on specific on mitochondria, and in these animals to show an improvement in ejection fraction and reduction in end-systolic volume. Now, therefore, we can optimize the myocardial activity a little bit with metformin, with tremetazidine, but also we can increase the ATP production by favoring the electron transport with Bendavia, as I showed you, and we have phase 3 trials ongoing with Bendavia, but also with iron that has the same effect on the mitochondrial crystin. And we know that patients with iron deficiency tend to, regardless of the presence of anemia, they tend to have less ATP production, and therefore its iron supplementation is associated with an increase in ATP production. The benefit of iron have been shown in the CONFIRM-HF, where ferric carboxymaltose showed a significant effect on 6-minute walking distance and decrease in fatigue score. They've been confirmed by the CONFIRM-HF, and very recently the AFFIRM-HF study showed a very significant trend towards reduction in hospitalizations and cardiovascular death in patients with acute heart failure receiving iron therapy, and that was mostly driven by a significant reduction in heart failure hospitalizations. So that was significantly reduced by more than 25%. Now, another optimization of cardiac metabolism is what has been shown with dapagliflozin. I mean, there's no doubt about the mortality benefit on dapagliflozin in patients with heart failure. Dapagliflozin is also the only one that has been shown to reduce mortality in patients with heart failure. And as you can see, the effect of the SGLT2 inhibition is of glyphosins, like in this case of empagliflozin, but also dapagliflozin, is to increase the energy production by increasing the glucose oxidation. So you see that all interventions that increase glucose oxidation lead to an improvement in event rates. So in conclusion, patients with heart failure have the metabolic disturbances that lead to less ATP production, that worsens the cardiac contractility, but also the diastolic function. The modulation of cardiac metabolism with different type of interventions always improves myocardial ischemia, left ventricular function, muscle strength, and prognosis in patients with left ventricular dysfunction and in patients with heart failure. What is important is that most of the interventions, especially iron and tremetazidine, have been shown to significantly increase muscle strength, which is a very important endpoint in patients with heart failure. So we can obtain an optimization of cardiac metabolism, mostly with inhibiting the free fatty acid oxidation, but also at the same time improving insulin sensitivity and improving the myocardial electron transport with iron, and we'll see in the future with Bendavia, And of course, all patients should be receiving treatment with the SGLT2 inhibitors. And I will stop here, and I will be happy to take your questions.
Thank you, Dr. Rosano, for that excellent talk, for enlightening us on the metabolic approaches to management of heart failure. So one of the audience who's there, Dr. B.K.S. Shastri, has raised a very important question. So he wanted to know, is there any interaction, clinically important interaction between metformin and SGLT2 inhibitors and cardiac myocytes?
Yeah, I mean, we have indirect data. We don't have direct data. We have indirect data from all the from the cardiovascular outcome studies with dapagliflozin, but also with empagliflozin and canagliflozin, where many patients were taking already metformin and where the effect were sustained. I mean, there's no additive effect. Of course, if a patient is on metformin and receives then an SGLT2 inhibitors, get a much greater effect.
Thank you. Any questions from the other panelists?
Dr. Rosano, one question. Trimetazine has been around for a long, long time. You have shown us very sound theoretical basis as to why it should work. How come it is still relegated to a periphery in the guidelines?
The main problem is that the drug was initially marketed in 1970s with as an anti-ischemic and lost its patent at the end of 1980s, early 1990s. And and when we started to recognize the benefit in heart failure, and by then there was no commercial interest in conducting a large randomized clinical trials. Of course, the last guidelines of the European Society of Cardiology have highlighted the importance of using trimetazidine, especially in the subsets of patients who are diabetics and with ischemic heart disease. We lack a large trial with Gabriele Fragasso and I and other co-workers have tried to raise funds for the study, but then the only study we managed to conduct was that patient study in 860 patients, where we showed that there was, even in a small patient population, relatively small, reduction in events. Of course, it would be important to see whether by raising further funds that would be effective. I have to say also that we often face different or inefficacy of different formulation of trimetazidine. And we noticed that the first time when we were doing some studies in isolated myocytes, where we found that some of the trimetazidine compounds were not working properly, and also with some generic formulations not working properly. So if you don't see the effect and you're using a generic, then probably you may want to increase the dose, because probably the dose is suboptimal.
Thank you.
So there are two questions from the audience from the webinar. We're just putting it up. Harikrishnan sir, you're muted.
Dr. Rosano, one question. Is it the ischemic cardiomyopathy patients, will they benefit, because there is some benefit in patients with angina? So will they benefit more, or most of your studies were on non-ischemic cardiomyopathy?
The effect is much greater in patients with in the elderly patients, in patients with ischemic heart disease, ischemic cardiomyopathy, in diabetic patients, so in patients with diabetes, insulin resistance, and in those patients with and heart failure. Of course, other studies, small studies, have shown an effect in dilated idiopathic cardiomyopathy. I would say probably I would focus first on those patients where it works most, and then maybe try as a last resource in all the others. But in patients with ischemic heart origin, I mean ischemic heart failure, diabetic with heart failure or elderly with heart failure, there is a clear benefit, which is not just cardiac, but is also extracardiac, as I said, which is focused also on muscle strength.
The diabetic patients have a high blood glucose level, but is it basically the problem of insulin resistance that lead on to the metabolic problem?
Basically, drugs like trametinib, and we have also data with ranolazine, by having an effect on the optimization of cardiac metabolism, basically they reduce the glucose, intracellular glucose levels, and therefore there is an improvement in glucose transport across the membrane. So it's we have both data with ranolazine and with trametinib that there's a decrease in HbA1c in diabetic patients.
Rosano, long ago, Arhexylene maleate used to be available under the name Pexid. I mean, I think about 30 years back, we used to use it for angina. Arhexylene?
Yes.
Is it still available, or is there any plan to revive it, as you showed?
Yeah, I mean, Parexelin is a difficult drug to use because it has been linked, especially in Australia, with some significant liver toxicity. There is evidence there are some specific genetics that are associated with liver toxicity with Parexelin. And at the moment is on the market in very few countries. I mean, it is very similar to trametinib, and and I understand that there are some labs that provide the genetic testing to look at the tolerability of the drug. And I mean, if it's tolerated, it works as trametinib. There's no reason to think that they should be different on the free fatty acid oxidation. The only problem is that trametinib is very safe. With Parexelin, you have to run extra tests.
Shastri has raised this question regarding the recent reports of Parkinsonism reported with use of trimetazidine. So, what is your opinion on that?
I mean, there's nothing at all. The European Medicines Agency looked into that in 2012, and that was prompted by the French Drug Authority that initially reported it. Then it was found that the occurrence of Parkinsonism is much lower than in a controlled population in France. And there have been two large post-marketing trials and studies looking specifically at Parkinsonism that did not demonstrate any increased risk of Parkinsonism. I mean, the old story started with a Spanish pharmacologist that theoretically said that since there is a piperazine circle, then that should induce Parkinsonism. And if that is true, it would occur the same with verapamil, because the piperazine circle is similar. So it's, but then it was just theory, and the post-marketing studies and the studies on drug safety never demonstrated, and actually they demonstrated that the occurrence is very, very low.
Some questions are posted by in the chat box.
Anand, can you just show the questions once again? Yeah. Okay. Renal dysfunction and trimetazidine. How to use? Is it risky to use it? Or?
Yeah, no, I will go quickly through all of them. I mean, in diabetic patients, it works well, regardless of the level of blood sugars. There's no reason to think that it works better in one or in the other. Even in patients with insulin resistance and normal glucose, it works. For Myocardial, there's no space. I mean, there's no evidence there has any effect in heart failure. And regarding renal function, I mean, it's of course it's a drug that is excreted by the kidney, and you can just reduce the dose. I mean, it's if you have an eGFR less than 45, then you go to just 20 milligrams BD. If it's up to between 30 and 45, you go to 20, and you get the same plasma levels.
I think the time is up. So thank you, Dr. Rosano. If there are no further questions, we will go to Dr. Venugopal's talk.
Thank you very much.
Thank you.
Thank you.
Thank you, Dr. Rosano.
Thank you.
Thank you.
Bye.
See you sometime.
Bye.
Venu sir, first you'll have to unmute yourself.
Venu sir, please unmute. We can't hear you.
Stop the presentation, sir. Stop sharing so that it's easier for you.
We can't hear you, sir.
1 minute, sir. I'll stop your sharing. Then first unmute yourself.
Sure. Okay.
Now you start sharing, sir.
Okay. Yeah. Okay, is it visible?
Yes, sir. Yes, sir. It's very well visible.
Okay. Thank you, Dr. Harikrishnan, Dr. Chopra, Dr. Bhagirath, and Dr. Jadhav for giving me this opportunity, and thank you, the chairpersons, for again chairing this session. Dr. Mohan has already talked to you about the use of echocardiography in the diagnosis and management of heart failure. And I'll be now talking to you about 3 other complementary investigations for optimizing the diagnosis and treatment of heart failure. These are the cardiac magnetic resonance imaging, cardiac CT, and the role of catheterization in heart failure. Now, I'll first start with the cardiac MRI in heart failure, because it is more applicable to heart failure than the other 2. Cardiac MRI is a very versatile investigation in heart failure. It helps in the diagnosis of heart failure. It allows you to diagnose the pathological diagnosis. It is described as a virtual biopsy by itself. It's useful in determining the prognosis, and it also helps in the role in management. When you look at the diagnosis of heart failure, MRI certainly has certain advantages over echo. That is, it is reproducible, multiple views rather than the standard views that you get in the echocardiography of multiple views. There is lack of inter-observer variability. There is high temporal and spatial resolution, and the ability for tissue characterization, which is the most important aspect of cardiac MR. We have to remember that it's a gold standard for assessing ventricular volumes, stroke volume, ejection fraction, and myocardial mass. And it's also useful for quantitative assessment of valvular flow abnormalities in the transmitral and the left ventricular outflow tract flows. And it's also useful for assessing the intracardiac shunts. We use a large number of protocols. The usual protocols that we use are the T1 weighted black blood spin echo, which tells you the anatomy, the steady state free precision, or the SSFP, which gives you the chamber volumes, the turbo spin echo based sequences for morphology, the phase contrast flow imaging, 3-dimensional steady state free precision for coronary angiography, and late gadolinium enhancement to inverse and recovery, which is one of the most important aspects of MRI that we use in our day-to-day practice. Just to highlight, in T1 weighted images, the tissue and the blood appears dark, and when you give contrast, the blood appears bright and the tissue appears dark. Whereas if it is T2 weighted images, the blood appears dark and the tissue appears bright with and without contrast. Now, these are some of the views that you normally use as a short axis view. The short axis view is normally used to assess the left ventricular volume and the ejection fraction. This is the 2-chamber view. This is the 4-chamber view. And this is the left ventricular outflow tract view. This I said earlier that there are multiple views that are available with cardiac MR more than the echocardiography, and therefore our diagnosis of the morphological diagnosis and functional diagnosis becomes much more easier with the cardiac MR. The imaging sequences are gated using a 3-lead electrocardiogram, and the ventricular series are imaged with a 12 to 25 phases spanning the cardiac cycle. Ventricular series in the cardiac short axis and long axis provide an accurate estimation of the following functional parameters, which I said: the ejection fraction, the systolic wall thickness, and the wall motion. Gadolinium is the agent that we use for contrast studies in MRI, and the gadolinium actually enters the myocardial tissue, and it washes out immediately. It's called as a wash-in, wash-out metabolism of gadolinium. The signal there is, if there are scarred regions, there will be signal enhancement in scarred regions, which will occur about 5 to 10 minutes after the initial contrast bolus. The scarred regions will retain the contrast agent as cell death and tissue edema, which occur after an infarction or scarring. After the will alter the wash-in and wash-out kinetics of the extracellular contrast agent, so that if you do a imaging after some time, the gadolinium is still there in the tissues, and this is what appears with the late gadolinium enhancement pattern. The pattern of late gadolinium enhancement is very, very important to diagnose the various etiologies. If you find that the gadolinium enhancement is more in the subendocardial region, it is most likely to be due to an ischemic heart disease. It can start in the subendocardial region and then spread towards the transmural. It can have a transmural infarction. The other condition where there is subendocardial involvement is in amyloidosis and systemic sclerosis. The area of late gadolinium enhancement is the mid-wall, which is characteristically seen in hypertrophic cardiomyopathy. In idiopathic dilated cardiomyopathy also, you have mid-wall involvement. Myocardial is known to have mid-wall involvement. In epicardial, the conditions which cause epicardial late gadolinium enhancement are basically sarcoidosis, myocarditis, Chagas disease, and Anderson-Fabry's. So looking at this pattern, it is easier for us to differentiate between the various etiological factors which cause myocardial dysfunction. This is just an example of a subendocardial infarct involving the subendocardial region. The rest of the myocardium is not affected. Whereas in a transmural, you find that the entire thickness of the myocardium is completely involved. And again, the cardiac MRI is extremely useful for assessment of viability. If you look at the thickness, if there is more than 75% of the myocardial wall is involved in the enhancement, that is a non-viable area. Between 50 to 75 is a borderline area, and less than 50, as you see in the lower panel, less than 50 there, the myocardium, less than 50% of the myocardium is involved. It means that the territory is viable. Therefore, cardiac MR is one of the very important investigations to assess myocardial viability. Cardiac MR in the etiological diagnosis, as we all know, the major cause of heart failure in India is coronary artery disease. Cardiac MR can differentiate ischemic from non-ischemic cardiomyopathy. It can also assess the function, perfusion, and viability. And it is an investigation of choice in a variety of non-ischemic conditions where the echocardiography may not really help you. The conditions non-ischemic where cardiac MR is important is dilated cardiomyopathy, myocarditis, hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, iron overload cardiomyopathy, cardiac amyloidosis, sarcoidosis, Anderson-Fabry disease, constrictive pericarditis, LV non-compaction, endomyocardial fibrosis, Chagas disease, and Takotsubo cardiomyopathy. So it gives you an entire list of diagnoses which can be made by cardiac MR evaluation. This is a classical example of an amyloid where you get a marked left ventricular hypertrophy and the cardiac MR showing diffuse subendocardial late gadolinium enhancement. In sarcoidosis, basically, as I said, it is a subepicardial, but usually the regions in sarcoid which are affected are the basal regions of the myocardium. This is a case of a left atrial myxoma, which can be very clearly seen in the cine film. This is an example of a thickened pericardium and constrictive pericarditis, and the classical septal bounce that you see in constrictive pericarditis. This is an example of a right ventricular endomyocardial fibrosis. Very often EMF is one of the commonest diagnoses that we used to come across in Kerala earlier. Now we are not seeing EMF due to mysterious reasons, but EMF can very easily be diagnosed by a cardiac MR. One condition where cardiac MR plays a major part in the diagnosis is arrhythmogenic right ventricular cardiomyopathy, where there is right ventricular dilatation, aneurysm formation, thrombus formation, and fibrofatty infiltration of the RV myocardium. And it's also seen that 30 to 80% of advanced cases of arrhythmogenic right dysplasia can also have left ventricular involvement. And it is one of the conditions that you have to differentiate when somebody presents with ventricular tachycardias. Hypertrophic cardiomyopathy, cardiac MR is one of the most important investigations that you need in hypertrophic cardiomyopathy. After the echocardiography has established a possibility of hypertrophic cardiomyopathy, cardiac MR will certainly help you in assessing the severity of the hypertrophy, the type of the hypertrophic cardiomyopathy, the left ventricular outflow tract obstruction, the systolic anterior motion, and also in prognosticating. The most important thing is, if you have a late gadolinium enhancement of more than 15%, these patients are associated with a propensity for sudden cardiac death, and this is an indication for putting an AICD in these patients with hypertrophic cardiomyopathy. Cardiac MR is not only useful in myocardial disease, but it's also useful in diagnosis of conditions presenting with acute heart failure like dissection. And though cardiac CT scores over cardiac MR in this situation, cardiac MR has also been used in stable patients with aortic dissection. One should also know the cautions with cardiac MR imaging. There are certain contraindications with cardiac MR. That is the presence of ferromagnetic aneurysm clips used by the neurosurgeons, the metallic fragments in eyes or other vital areas, pacemakers, the MRI incompatible pacemakers, ICDs, the previously used prosthetic valves like the Starr-Edwards ball and cage valves, the insulin pumps, and neural stimulators. We have to know that the sternal wires and stents are not contraindicated for a cardiac MR evaluation. Well, as far as gadolinium is concerned, it can cause significant renal dysfunction in the form of nephrogenic systemic fibrosis. And it is not advised in patients with the GFR, which is less than 30 ml per meter square. Coming to the next investigation, that is cardiac CT in heart failure. Cardiac CT is a very useful tool in heart failure for diagnosis and management. It is far more widely available compared to cardiac MR. And the most important aspect is that it is ideal in situations where an MR is contraindicated due to the reasons which I mentioned above. If you look at cardiac CT, if you look at the coronary arteries, coronary artery calcium, we know that has a very high predictive value for future events. Coronary CT angiogram has a high negative predictive value for events. And we have to remember that coronary CT angio has now been accepted as per recent data. Coronary CT angio has been accepted as a substitute to invasive coronary angiography when somebody presents with acute heart failure. Once heart failure has been stabilized, people have started using CT angiogram to diagnose or to rule out ischemic heart disease or obstructive coronary artery disease. We know that there is emergence of CT-FFR will make this modality of CT angiogram far more useful in future. The other uses of cardiac CT is for cardiac vein assessment for CRT, assessing the left ventricular volumes and ejection fraction. It has been found that there is a very good correlation with MRI and echo for CT, and the CT is also useful for ascertaining myocardial perfusion defects. The size of the infarct can be assessed by delayed enhancement. The RV function can also be assessed very well by the CT. And another new indication for cardiac CT is in patients who are undergoing atrial fibrillation, a pulmonary vein ablation. Studying the pulmonary veins is extremely good with the cardiac CT. In diagnosis of heart failure, reduced ejection fraction, reconstruction of images at multiple phases across cardiac cycle is possible, and calculation of ventricular volumes and ejection fraction for LV and RV function is possible. In heart failure with preserved ejection fraction, the role of cardiac CT is not as well validated as cardiac MR. Regional wall motion abnormalities can easily be assessed by cardiac CT by assessment of mechanical dysynchrony is comparable with accuracy comparable accuracy with echocardiography has been demonstrated. And again, mechanical dysynchrony, as you know, is again the demonstration of this is very important as far as CRT is involved. This is just an example of the various views that you look in the CT angiogram to demonstrate the regional wall motion abnormalities as well as calculation of ejection fractions. Now, we know that calcium score, the Agatston score is very well known to all of us, and depending upon the calcium score, 1 to 0 is considered to be normal, 1 to 10 is minimal calcium involvement, 11 to 100 is mild, 101 to 400 is moderate, and more than 400 is considered severe. And the calcium score really tells you that there is a regression of atherosclerosis, and it has been used as a parameter of choice, especially in population studies, to understand the possibility of primary prevention of coronary artery disease. This is just a demonstration of the calcium in the coronary arteries. And this is just a demonstration of the reconstruction of the coronary arteries by CT angiography. And this is again a demonstration of a tight left anterior descending artery occlusion, which is filled distally by right coronary artery collaterals. Another important aspect of CT angiogram is to demonstrate coronary artery anomalies. And I think this is extremely important as in the diagnosis of coronary anomalies, probably even more useful than the conventional angiogram. Sometimes you may miss this. This is extremely important. If you look at the comparison of the various screening tests, CT angiogram has a sensitivity of 89% and specificity of 96%. Nuclear medicine 70 to 80, SPECT has a 70 to 80%, specificity 70 to 80%. Stress echocardiography 70 to 80%, specificity 70 to 80%. Our exercise testing has only 60 to 65% sensitivity and 70 to 75% specificity. Cardiac cath is 100% sensitive and specific. CT has also role in cardiac veins and pulmonary veins, as I just mentioned earlier. In CRT therapy, it is useful for coronary vein anatomy determination, and it helps in avoiding areas of scar. Pulmonary vein imaging is extremely important in atrial fibrillation ablations. One major use of cardiac CT is in post-heart transplant patients. One of the major problems that we come across in heart transplant patients is coronary allograft vasculopathy. It may affect close to 50% of heart transplants. And CT angio is probably better than invasive angiography, because in invasive angiography, one may find only very minimal lesions, and we may tend to ignore these lesions. But CT angio tells you gives you much more information, and it has been compared with intravascular ultrasound. And early diagnosis of coronary allograft vasculopathy may be beneficial for the patient as far as the management of the patient is concerned. The use of CT in LV assist device also upcoming. CT angiogram allows visualization of inflow and the outflow cannulas and determination of thrombosis in the devices. Cardiac output can be determined in continuous flow LVAD with dynamic acquisition. Again, cardiac CT in emergency department is an extremely important investigation that will come out when a patient comes with chest pain. There's a triple rule out, which has been mentioned earlier in one of our seminars. It rules out aortic dissection, pulmonary embolism, and acute coronary syndrome. And it's a boon for the emergency physicians. CT has certain limitations. It has high radiation. It requires slow heart rates. It may not be useful in arrhythmic situations like atrial fibrillation. It uses iodinated contrast, and risk of allergic reactions, nephrotoxicity is well known. Now, coming to the third aspect of my talk, that is cardiac catheterization heart failure. The role of cardiac catheterization is one in establishing diagnosis. The most important aspect of cardiac catheterization will be to do a coronary angiography to differentiate between obstructive coronary artery disease versus non-obstructive disease, non-obstructive conditions causing cardiomyopathy and heart failure. Cardiac catheterization is extremely useful in hemodynamic evaluation, in pulmonary artery hypertension, in constrictive pericarditis, especially when you have a doubt in occult constrictive pericarditis, in invasive monitoring in acute decompensated heart failure, and also in CRT and ICD. What are the indications for hemodynamic monitoring? Invasive hemodynamic monitoring is not indicated for stable patients with heart failure who respond appropriately to medical therapy. The one trial which studied this was the ESCAPE trial, which showed no mortality benefit or hospitalization benefit in patients with stable, patients who are heart failure patients with stable, who are in stable state. In patients with acute decompensated heart failure, the following are the indications for invasive hemodynamic monitoring. That is, patients with respiratory distress or impaired systemic perfusion when clinical assessment is inadequate, in acute heart failure with persistent symptoms despite standard therapy, uncertain fluid status, perfusion, systemic vascular resistance and pulmonary vascular resistance, systolic pressure that remains low or associated with symptoms despite therapy, worsening of renal failure with therapy, requiring anotropes and needing mechanical circulatory support. Routine invasive monitoring in normotensive patients with acute decompensated heart failure is not indicated. In pulmonary artery hypertension, the indication is to make a definitive diagnosis of pulmonary hypertension, measuring the pulmonary pressures accurately and conducting a vasoreactivity test for assessment of acute response to vasodilators. Vasoreactive testing is indicated only in expert centers. Vasoreactive testing is recommended in patients with idiopathic pulmonary artery hypertension, heritable PH, and PH associated with drugs, which can be treated with a high dose of calcium channel blocker. A positive response to vasoreactivity testing is defined as a reduction of a mean PA pressure by more than 10 millimeters of mercury to reach an absolute value of mean PAP less than 40 millimeters. Nitric oxide is recommended for performing vasoreactivity. Intravenous epistrone, adenosine, and inhaled can also be used. I'll just skip this slide. In conclusion, cardiac MR, CT, and cardiac cath are complementary investigations in patients with heart failure after a detailed clinical evaluation echocardiography. The choice of the investigation should be after assessing the risk-benefit ratio, especially in sick elderly patients with comorbidities. Proper selection of the test will go a long way in the optimal management of patients with heart failure. Thank you.
Thank you, sir, for this excellent talk. It's a very huge talk. I do not know how you managed to compress all these things into 20 minutes. That's a huge task. So the questions from the panelists.
Yes.
Gopal, if I may ask you one question.
Yes.
How has been your experience about the correlation of echocardiography and CMR? How do you look at it, both in terms of, let's say, a good echo with strain imaging done and then a CMR? At times the cardiologists say we are not getting the same information from the imaging guy, or it looks completely different.
See, one important aspect of cardiac MR is that irrespective of patient's echo window or this and this thing, you get absolutely good images. So there is no problem. See, in echo, very often we find that obese patients with COPD, you don't get good images. You struggle to get good image. Your calculations, everything may not be correct. Whereas in cardiac MR, there is absolutely no problem. The echo, the window is not a major issue at all. So that is probably the reason why it is the gold standard. If you ask my personal experience, it's very difficult to comment because our own center, we don't use cardiac MR that frequently as the echo. So obviously, see, the echo is much more commonly used. But if you ask me regarding the utility and the definitive diagnosis, I think CMR may be the investigation of choice.
Especially in patients with heart failure with preserved ejection fraction, when you are not getting any information from much information from the echocardiography, I think that is a very important tool.
Exactly.
But personally speaking, I would say that getting a patient into an MRI, very difficult. There are a lot of them, at least some 20 to 30% of them run out of the MRI saying that they are claustrophobic, and
exactly.
my colleagues who we had to give him full anesthesia to get his cardiac MRI done. That is a very, very
One of the
scary stuff.
side effects I forgot to mention was claustrophobia. Certainly, it is very, very important.
Venu, one question.
I just wanted to add a point to what Venu sir just said. So MRI would be a one-stop shop for giving a complete comprehensive view of heart failure. The reason why I'm saying this is you have a three-dimensional assessment. So many times the ventricle, especially in ischemic cardiomyopathy, may have small aneurysms, which if you take in an echocardiography, unless you do a 3D volume rendition, you may not get an accurate EF. That is one point. Second thing is the scarring and the amount of fibrosis is very well perceived on an MRI. So especially if you want to predict what is the likely recovery of a patient, wherein you're not sure, you're seeing the patient for the first time, you don't know whether this patient is going to recover with medical management or likely to remain with a decreased EF. The fibrosis score will tell us whether there is a likelihood of recovery. The other thing is in heart failure, preserved ejection fraction, particularly hypertrophic cardiomyopathy, we use the fibrosis score to decide on the need for implanting an ICD. I think this is Narasimhan sir's territory, and he would be able to give us more information on this. So even though we go through the paces of doing ECG, echo, as well as a CAT study, I think all patients necessarily undergo a cardiac MRI. I think Dr. Santosh's comment regarding getting them into the MRI is well taken. We do have certain processes wherein we can keep the patient entertained during an MRI if that makes them more acceptable to an MRI. But yes, end of the day, as far as possible, whether sedated or not, we try to make it mandatory for all patients.
I think the developments in MRI is one of the things that they are going to look at is shortening the time of the examinations. Currently, cardiac MRI takes about 30 to 45 minutes. Probably one of the things that is coming in is a shorter acquisition time for images. Probably that might make it much more acceptable to the patient. But as you said, tissue characterization, probably MRI is
over any other model.
Because once you do an echo, you are not able to see the tissue aspects of it. It's like a virtual histology, as I said earlier. You get all the things. So that way it is. And heart failure, preserved ejection fraction, certainly. It will be this thing.
Dr. Venu, one question. Many times there's a problem that it's an asymptomatic person who for some reason has got a coronary CT angio done and it's a high calcium score. Totally asymptomatic is able to walk around 2 or 3 kilometers, and you say it's got only a 70 to 80% sensitivity and specificity. Does it mean that the person has to go for an invasive angio, or would you be happy settling with a stress thallium or something like that?
I would be, see, one of the things said about coronary calcium is that if you have very high scores, over 1,000, actually it doesn't help you really.
Yes.
It doesn't really help you. So you have to look at the patient as a whole. You can look at the other parameters to see perfusion studies and then only take a decision. Any value over 1,000, actually it gets clouds your decisions. I have a friend of mine who walks around, who is a sportsman, who's this is more than 1,000.
Dr. Venu, I want to ask you a question.
Yeah.
How often you use, or anyone here, how often you use scar burden to decide between CRT-P and CRT-D? Is it a valid argument?
Honestly, I can't answer, Dr. Narasimhan is there to answer for me.
I tend to use for patients who are with borderline finances. If there is completely no scar, I tend to give them just the option of CRT-P and optimal medical therapy. So there are several patients who can just barely generate about 4 lakhs, but they can't get you 8 or 9 lakhs. So in those patients, I use it as a soft endpoint to go ahead.
I think it's very important in Indian context.
Yes.
MRI cost may be at most 10,000-15,000.
Yes.
The cost difference between CRT-P and CRT-D is 3 lakhs.
Yes.
4 lakhs.
4 lakhs.
Another question, Dr. Venu, is that you mentioned that acute heart failure, CT angio is a preferred method.
It's not, I didn't say preferred, but there is studies which have shown that you can use a CT angio also to rule out.
When the person is coming out of acute heart failure, you can finish an angiogram in 20 ml of dye or less.
Yeah.
While CT angio is going to require a lot more.
No, I'm just quoting a reference that they have studied whether this is possible to do in this situation of acute. Once a patient is stabilized, whether they can do CT angio instead of a coronary angiography and see whether they can rule out ischemic heart disease. There is just a reference which I came across. I do agree that in Indian situation, I don't think that we are going to take the patient for a CT angiogram. We are going to take the patient to the cath lab and do the coronary angio and rule out an ischemic heart disease. I was only mentioning that CT angio, there are some references where they have used it.
Yes, if I may add, you can also combine it with a right heart study when you're doing the invasive angiogram. And most of these patients have a deranged renal profile. So you can minimize the amount of contrast that you can use, especially if you're doing an invasive angiogram.
Sir, coming to Dr. Chopra's point about calcium score, if you have a very high calcium score in a young patient, say less than 50 years, and it may be, it's not there, I agree, it's not in the guidelines, but it will be a softer indication for an invasive coronary angiogram. Suppose a 65-year-old diabetic with calcium score of 1000 is different from a 40-year-old non-diabetic with a calcium score of even 300.
Sure, I fully agree with you. Yeah, so I think
may I quickly
patient's context.
So may I quickly add something from my experience? I work with cardiac CT daily, so that's my job in the hospital. One is that for the benefit of our viewers, the Society of Cardiac CT has issued a new guideline in 2021 January. We should look at it. It's really putting all the evidence together. So a couple of quick comments. If the calcium is more than 1000, it's not innocuous. The calcium tells us that there is a presence of atherosclerotic plaques, and it's not necessarily related to calcified plaques. There can be soft plaques also. So if you have high calcium score, you need a physiological study. This is where even a simple treadmill exercise test will help us understand whether the patient has a ischemia and angina or he does not have. So we put it this way, and this is what SSCT also recommends. If you start seeing a calcium above 400, it will be nice if we can do a physiological testing and get information. So that's one. And second, young patients with cardiac CT. So I'll tell you today's example. We had an infarct 3 years back of a smoker. I did his calcium score before we took him for cath. It was 49. And with the inferior wall, patient responds very well to a thrombolytic therapy taken for a cath, shows extensive triple vessel disease with left main and mixed plaques all over the coronary arteries. So I think young patients with calcium is not great news. Elderly patients, maybe there could be calcium in the adventitious, but all calcium is no innocuous thing. We must look at it here.
See, we are saying that only zero calcium is important. Any calcium is significant.
Absolutely. Well said, Venugopal. I think Hari and Vijay, we are exceeding time. Shall we go ahead with the next?
Dr. Uday, there was one question from the audience. You want to take that? Quick question.
Yes, please. Yes, please. Please. So if it is, I can only, Venu will tell us about MR.
You can talk about the CT, yeah.
If it's 64 slice CT and above, that's the requirement for a cardiac CT. You cannot do a cardiac CT below 60. Now, yes, 64 works, please. Let's make no mistake. Now, if you want a iterative reconstruction or higher end gadgets, you can go at 128 and beyond. But 64 works very well. For MR, 1.5 Tesla also works. Venugopal can tell us that. And if you are 3 Tesla, you just need to put the loop, right? You need just to put the cardiac loop and that's it. Yeah, Venugopal.
Yes, I fully agree. 1.5 Tesla is enough as per the current standards. Obviously, when you have a 3 Tesla, you may have a better facilities, but I think 1.5 Tesla is enough.
0.5 Tesla is the mostly used in cardiac MRs.
Sir, I just want to add one point quickly. if your focus is purely the coronary anatomy, then CT would come in handy here. But if you're looking at a comprehensive view, then definitely MRI scores over. Only thing is MRI cannot see cannot tell us much information about the coronaries per se. It would be able to give us indirect evidence in terms of myocardial perfusion. The 1.5 Tesla and 3 Tesla, in terms of image quality, not much to choose. Maybe this is more Narasimhan sir's territory, wherein if you're using devices, the older devices, 1.5 Tesla, then that there the differentiation becomes necessary. But the images are just as good, and the information that we obtain by 1.5 Tesla is comprehensive.
Yeah, one more point is that the threshold for doing a coronary angiogram, especially in Indian patients, should be very low, because many patients, especially in patients in 35, 40, when they come with severe LV dysfunction, many of the time when we do angiogram, we find significant coronary artery. So it's always better to err on the side of doing a coronary angiogram rather than not doing it.
Yes, agreed.
I think we'll go on to Professor Narasimhan.
Go to the next section. Yeah. We are all eagerly waiting to listen to Dr. Narasimhan, Master Teacher's case presentation, sir.
Oh, thank you so much for the kind invitation, Chairman, ladies and gentlemen. I thought I'll just take two cases. I would like to thank my colleague, Dr. Sridevi and Muthaiya, who had contributed to this from the device clinic. First is a 63-year-old gentleman with hypertrophic cardiomyopathy, LV dysfunction 45%, presented with near syncope twice, palpitation, and had runs of NSVT on Holter and patchy scar in the septum. And he underwent a dual chamber ICD implant, recovered well, started on bisoprolol, lacilactone, ramipril, and amiodarone, and was discharged. This is the electrocardiogram. You can see some fractionation of the QRS, a little bit of an IVCD, and an occasional three different morphologies of PVCs occurring through the strip. He came back with a little palpitation, was doing well. This is the initial echo. I hope it plays okay. As mild LV dysfunction, mild MR, was doing very well for almost about 3 years. Then suddenly came to the ER with severe pulmonary edema in the early hours of the morning. Started by the ER team with IV Lasix, started low-dose dobutamine, didn't improve, started on NIV, and then next morning when we saw the blood pressure was 100/80, had a mild TROP-T elevation, and on NIV he was maintaining 90. And he was taken up device-wise, longevity and thresholds, impedance, everything was normal. No evidence of atrial or ventricular arrhythmia on the device. And then he was stabilized, and then subsequently he underwent an angio which just showed large vessels, ectatic flow. Sleep study was very mild sleep apnea. No atrial or ventricular high rate episodes on device interrogation. He was discharged. A couple of days later, he gets readmitted after a week with severe LV dysfunction, almost to the point of being, I don't know whether he got ventilated once. Improved again with Lasix drip, dobutamine, and NIV. And next morning they saw everything was same, unchanged. EF had slightly gone down, and PAH has developed a PA pressure of 50, and he had gone into congestive phase. So this person was a very affording businessman. He wanted to know what the other options are. He was going into congestive phase of cardiomyopathy and 2 episodes of pulmonary edema. Again, when we went through the story, what we realized was this patient had 2 admissions. Both of them were early hours of the morning. And at that time, the echo showed, this is not, because no one did the echo in the night during pulmonary edema. We couldn't find out what was happening. And then when we deliberately shortened the AV delay and made him ventricularly pace, he started developing severe MR. So if you looked at the original device interrogation, the percentage of pacing was very minimal. And all of them were happening only during the nights when the patient had a little lower heart rate. So what had happened was this patient had come with a little palpitation and was seen, and the dose of amiodarone was escalated about a month prior to all these things happening. And he was having significant nocturnal bradycardia, and which necessitated RV pacing. So what we did was we forcefully paced the RV to see what is happening, and we brought out the severe MR. And so we spoke to him, even though it is only a 3-year-old device. We decided to upgrade the device to BIV, and it's 2018 we have done, and it's about 3 years. Patient is doing well, functional class 2 on the usual medical management. Now that he has a defibrillator and a thing, we have withdrawn and taken off his amio and just escalated his beta blocker to the maximum tolerated dose. This is the first case. Any questions or comments I would like to? Am I audible?
Yes, sir. You're right.
Yes, yes, sir.
Okay. So let me move on to the next case. This was recently published, 2 of our cases, and this is one of them. 58-year-old person had a class 3 dyspnea, progressive over 5 months. Presented to us with severe left ventricular dysfunction, EF of 27%, mild MR, no past history of hypertension or CID. Blood sugar is borderline, A1C of 6.8. He presented to us from outside clinic, already on torsemide, enalapril, aldactone, and carvedilol. And this was the electrocardiogram, class 3, severe LV dysfunction, left bundle. There's a notching of QRS fitting into Strauss criteria, being a typical left bundle branch block. And this was the state of presentation. Routine evaluation was all normal. So he undergoes a coronary angio, which was mostly normal, except for reported as mild narrowing on RC, otherwise normal. So the investigation is how to proceed at this stage. Any suggestion from the audience?
Within LBB, for sure CRTD should come in, and this should be supplemented with sacubitril valsartan and SGLT2 inhibitors according to the available evidence.
Guidelines, that's right. So this has been probably that's what we should have done. So anyway, while evaluation, we found that his cardiac PET was positive. He had a lymph node in the neck. Biopsy showed a non-caseating granuloma. He was started on immunosuppression. Heart failure resolved. EF improved. And most importantly, the LBBB disappeared. The QRS became narrow. He was started on methylprednisolone and methotrexate, 15 milligram per week, and after 4 months we obtained this. This was normal. So generally our protocol is, once we see a good improvement, we continue the methotrexate for at least 2 years, but start coming down on methylprednisolone to avoid steroid side effects. So we withdrew all these things, and a year later he presents again with severe LV dysfunction, and repeat PET shows an increased uptake suggestive of reactivation of cardiac sarcoid. And he couldn't afford biological, so we started to use IV cyclophosphamide as a rescue therapy, steroids and intermittent IV cyclophosphamide. So baseline LBBB resolved, withdrew therapy, LBBB reinstituted, LBB resolved. And this is what happened to this. EF was about 30% initially, improved with treatment, did very well for a while, and then on methotrexate we saw a decline and reinstituted, but this time we gave monthly pulses of cyclophosphamide, and on follow-up the EF has really normalized. So severe LV dysfunction, reactivation of sarcoid, resolved with steroids and IV cyclophosphamide. So this refractory heart, we had 2 such cases. So together, one of my colleagues put it together, wrote a papers in IPEJ. This month it's coming up. Refractory heart failure with left bundle branch block can be the initial manifestation in a patient with cardiac sarcoid. High clinical suspicion and early diagnosis are the key. Resynchronization is very useful and should be considered only after evaluation and treatment of potentially reversible causes. This is our recent JACC paper that we saw. Even in patients with very severe LV dysfunction, almost listed for transplant, if you have a very high FDG uptake, it tells you that the inflammatory burden is very high. And in these patients, despite advanced heart failure, if there is a lot of inflammation, they respond very well to immunosuppression. On the other hand, patients with very little inflammatory burden, predominantly scar-related phase of the disease, you should probably list them very early for either transplant or LVAD, whatever is advanced mechanical therapy rather than this. So I think I would like to thank all my colleagues for helping me to put up these two cases. Thank you so much for the
Excellent. Very good cases.
Excellent cases. Sir, one question, sir. How did
Yes,
you
please.
suspect sarcoid, sir, in the second case? Why did you think of FDG PET as a, what made you consider that?
See, the thing is, whenever a patient does not have a known cause for the heart failure, commonest cause is either ischemic heart disease or hypertension. And second thing is when there is no family history, no exposure to chemotherapy or any of those, we label them as unexplained heart failure. Unexplained heart failure could be occult sarcomeric mutations, or it could be inflammatory disorders. If it's a sarcomeric mutation, I'm not going to do anything, although things may change. So it has been our policy to go through in detail, and we find approximately 15 to 25% of them have inflammatory myocarditis, even in not necessarily with ventricular arrhythmia, they present with heart failure.
So in your so-called dilated idiopathic cardiomyopathy, are you saying that you pick up nearly 20% of patients with inflammatory disease who improve?
Yes, yes. I mean, we pick up inflammatory disease, but I haven't looked at that population, how many improved, because how many were, we are really learning as we go on, because some patients we have lost because of very aggressive immunosuppression, and they go elsewhere, opportunistic infections, they don't make it. So it's a mixed bag, and we work very closely with both the immunologist as well as the pulmonologist running a dedicated sarcoid clinic.
I think, Narasimhan, there is a referral bias. See, you are an expert and acknowledged expert in this area. So people like me, we suspect any sarcoid or inflammatory cardiomyopathy, we refer to you. So
you're very right. There is a referral bias, no doubt about it.
Narasimhan, sir.
You had a series
most of the centers, in fact, still we rely on CMR as our first stop.
Yes.
So are there any concerns about the specificity of reporting cardiac sarcoid on CMR in your experience, and how do you explain that?
Yeah, in fact, we are trying to look at our own data. We prefer, because of the limited cost that most patients have financial constraints, we are trying to write a paper saying that probably we should go with, whenever you're suspecting inflammatory cardiomyopathy, better to go with PET rather than MR. The reason is PET tells you whether there is an active inflammation or it's a burnt out inflammation. Number two, it tells you where to go and do a target for biopsy. Suppose you know RV apex doesn't have active inflammation, your endomyocardial biopsy is going to be negative. We would target the area where FDG lights up. Most importantly, we have looked at steroid resistant sarcoid happens in about 20% of the cases. So to follow up, when a patient doesn't improve at the end of 3 months, if the patient has been on steroids and methotrexate, fails to improve, we repeat a PET. And PET shows residual activity, we hit them. If a person can afford, we ask them to take biologicals like adalimumab. Whereas if the patient cannot afford, we give a monthly dose of IV cyclophosphamide.
But if somebody can afford, you would like to do both MR and PET?
Yes.
That's right. That's right.
I think that is a very important point, I think. Because we
PET
are
MRI is available in 1 or 2 centers in the country.
Yeah.
If you have the luxury, you can go ahead with that.
Regarding the first case,
Yes.
instead of going in for LV pacing, I do not remember what the patient had. LVBB, and the patient was having RV pacing, which caused pulmonary edema, no, sir?
No, the patient did have, he
MR.
just had an IVCD.
Oh,
He just had an IVCD. We didn't want him to pace the ventricle.
okay.
What happened was we kept on increasing the beta blocker amiodarone to suppress the PVC. Down the line, he started pacing the ventricle, especially at night. And while pacing the ventricle, the QRS became very wide and started having severe MR. So he was getting discharged on 2 different occasions, saying that it is unexplained heart failure, and then he was taking second opinion from his colleagues abroad and other things. Then we had to bring him to one of my colleagues, Dr. Raghu, was there in the echo room. In the echo room, we started pacing the ventricle. We could show a severe mitral regurgitation when we paced the ventricle.
So the patient proceeded to get a CRTD.
That's
graded.
right. That's right.
Decreasing the beta blocker and amiodarone dose, that could have helped, or?
Yes, probably yes. The thing is, he was requiring a high dose to suppress his PVCs also. Frequent PVCs, and was causing a problem.
In this situation, what kind of a PVC suppression would you be happy with? Would they be
because these patients, we tend to use a combination of mexiltine and amiodarone as a combination, and try to get near total suppression of the PVCs.
But what is the minimum with which you could live with?
No, it all depends on the symptom. If a patient has improved, even if he has a couple of PVCs, I'm not going to be worried. But if his patient's BNP is high and his functional class is not improved, I would like to suppress the PVC, almost eliminate it.
You won't think of doing, okay, they are multifocal. Otherwise, you would do ablation or something.
For HCM, such a thick septum, it's difficult to cause transmural lesions. So it's not a good substrate to ablate.
But otherwise,
you're not audible.
Otherwise, if it was a dilated cardiomyopathy with
yes, we would have gone ahead with the ablation.
Even if there's more than one morphology?
Yeah, we have surprisingly what we find is a very small scar. If it exits on the right ventricular side, it will be LBBB. If it exits superiorly, it will be 1. So the scar itself is small, but you may have different morphologies. Okay. You do what is known as a core isolation of the scar there.
See, Dr. Narasimhan, when we are talking about PVC burden and LV dysfunction heart failure, it may not be PVC burden alone which is responsible for the heart failure. There must be myocardial factors. Otherwise, we have got patients with galloburden VT or issues burden sometimes all the time in VPCs, good LV function, structurally normal, they won't go into heart failure.
You hit it on the nail. In fact, if you increasingly look at it, we have been under-recognizing titin mutation, titin truncation. These are the patients where even though all of us take alcohol, only some of us will develop cardiomyopathy. And the titin truncation forms about 30% of dilated cardiomyopathy. And as you said, patients with some kind of myocyte dysfunction, if they have a lamin mutation and frequent PVCs, even if you get rid of the PVC, their LV function will not improve. Whereas if it's titin, generally they have almost 15 to 20% improvement there, the LV function, if you suppress the PVC. In other words, the loading conditions matter a lot in titin mutations. So you're absolutely right. There is an underlying disease why the PVC becomes important.
So there are 2 questions from Dr. Kiran Makwana on air from the audience.
What are the measures to reduce recurrent admissions for DCM? I think it's optimizing the medical therapy because I think, Dr. There are very good talks in this forum. As you start treating these patients with DCM, after 3 or 4 months, you can uptitrate the medication. And the main foundational therapy has to be optimized. And despite that, they have recurrent heart failure, you need to see whether there is a trigger like like alcohol or something else which is worsening. You need to kind of get a specialist consultation and treat it.
Somebody has 15 to 20% ejection fraction and recurrent hospitalizations. Depending on the clinical scenario, whether you should go for transplant or LVAD.
Right. Bhagirath can.
Bhagirath, I think.
Bhagirath?
A lot of it depends on the right ventricular function. If you have biventricular dysfunction, then this patient is either a candidate for a transplant or a BIVAD. BIVAD, in terms of budget, is enormously expensive. So I think if the pulmonary vascular resistance PA pressures are suitable, then transplant should be the first choice. Obviously, we have to rule out all other contraindications, including age, frailty, and other things. For a single chamber ventricular dysfunction, particularly the ischemic cardiomyopathy variant, then LVAD becomes a good choice because most often the right ventricular function is normal. So in that case, an LVAD would be a better choice.
So here the point I want to make is a lot of the audience who are physicians,
yes, sir.
They continue to manage these patients medically till
Yes,
the
sir.
time they become, end-stage heart failure with multi-organ dysfunction and developing pulmonary hypertension, not suitable for transplant. As you said, BIVAD is a difficult choice. So
Yes, sir.
the whole purpose should be to sensitize.
Send them early. Yes.
Requiring second hospitalization within 6 months.
Yes, sir.
You should raise a flag and say, I am missing something, and does he require some mechanical or transplant therapy?
Yes, sir. Because readmission rate reflects mortality rate. So we have to sensitize these patients about the need for more advanced therapy. So be it LVAD or a transplant, they should be immediately told that this is the way forward. So we'll have to discuss these options. Also keep the physician in the loop so that they can participate in the treatment.
Even some of the state insurance schemes also now cover heart transplant. So I think the option of heart transplant should be considered for this end-stage heart failure patients where there is no treatment. Tamil Nadu, they give this, they cover heart transplant also. I do not know whether other states like Andhra Pradesh, Telangana, and other states, do they have state insurance covering transplants, or is it only for Tamil Nadu?
We've had patients only from Tamil Nadu, though we've asked patients from Andhra for transplant. That at present the budget does not cover that. Even in Karnataka, there is a new legislation to effect that transplant will be covered. However, it is yet to come into place.
I don't think it is covered in Kerala.
In Andhra, they give, but the money is not sufficient. Bala came out with a paper that the minimum cost will be about 16 lakhs or something. So somebody should influence the governmental agencies, both at center and state, that it can be patient can share the burden. It's not necessary that the government gives all the 16 lakhs or 20 lakhs or whatever. There should be a provision that both the patient and the government can share, and probably that is the way to go forward.
So there is a problem with this because invariably what happens is it's a blanket amount. So there is no flexibility in case the patient requires a longer duration of stay, if he requires dialysis or some other forms of support like Centrimac for some time, then these are not covered in the package. And as per the clause, you cannot charge more than whatever is the amount. So this is a deterrent for hospitals because you cannot exceed that budget. Whatever you do, you have to, the payout is fixed amount.
That's what I'm saying. Instead of making the government paying the whole thing, sponsoring the whole thing cost, pay some lump sum amount of 5 lakhs, 10 lakhs, at least the patient burden comes down. So we have to find a via media. Otherwise, see, out of 100 transplants you do, 15-20%, let us say, require some extra care and other things. But 80% we are losing, no?
Yes,
So
sir.
there should be a
This
provision.
copay facility is not available, sir. Whatever the government gives, that's it. So the patient doesn't have the flexibility. Same as in stents. They get the whatever stent is approved, only that stent you can use. You can't pay extra and get a better stent.
Because once we gave, some resident in Jitmar gave one clopidogrel tablet to be bought outside for a patient because we ran out of clopidogrel. The patient bought 4 clopidogrel and then they said we are cancelling the approval for the angioplasty. I mean, not even a
you can't pay. You can't charge anything outside.
So did they cancel it?
No, then we had to tell them, no, we will pay back the patient the money that was patient had spent.
Hari and Venu, you should be seeing it more often in Kerala, I think.
So we refunded the patient the money and patient said that, no, I got the money back from the doctor, so no problem. I'm happy. So the patient has to certify that I have not spent even 1 paise. When they get discharged, then only the bill is passed. That's a problem.
10 rupees saved your institution. I think we need to close probably. Excellent. Very good.
Thank you for all the speakers and thank you, sir, for that very eye-opening 2 cases. We'll remember it for all of the rest of our lives. These are very, very important lessons from. Always, it's a pleasure listening to you, sir. Thank you, all of you. Thank you so much.
Thank you. Good night.
Right.
Narsimhan. Bagheera?